And Niamh again has kindly made herself available this afternoon to talk about the coagulation aspects. Dr. Niamh Connell will talk about coagulation in the COVID-19 patient. And of course, Niamh is a consultant hematologist at St. James's Hospital and in the past, of course, at Tala University Hospital. And she's now also director of the National Haemophilia Centre and is an expert on coagulation. And again, Niamh, I would ask you if you could be available, please, at 3:40 this afternoon. We'll take all the questions there. Thank you, Niamh.
Thank you very much, Jared, and to all of our colleagues. I hope you can hear me okay. I'm delighted to be invited to this illustrious meeting. You've got some fantastic speakers. I very much enjoyed Professor O'Neill's talk just now, and it certainly is, every time I hear him speak, there's some new information, and that was really helpful to have him distill it for us. I'm going to focus on a much more clinical topic now, though, which is the effects on the coagulation system and the consequences of changes in the coagulation system for people who are unfortunate to be infected with COVID-19. And I'll just start by, I suppose, reminding us all, just 1 second till I see if I can move my slides. Okay, sorry, there's a slight technical problem here. 2 minutes. The interplay between coagulation and inflammation has long been known. This is a slide which describes what's happening in people who have asthma, but I think we can probably understand that the same process can also be happening in people who have infectious diseases such as COVID-19. So you have the expression of procoagulant clotting factors, particularly related to activation of the endothelium and expression of things like tissue factor, activation of platelets, and then often a dysfunctional fibrinolytic system and reductions in natural anticoagulants. But there's this very important interplay with the inflammatory system which is going on side by side. And the other thing I'll draw your attention to is the co-location, really, of the alveolus right next to these small pulmonary blood vessels, so that the possibility for interplay between the two regions, the blood vessel and the alveolus, is very marked with flow of cytokines and inflammatory mediators and coagulation proteins in both directions. I suppose one other thing to bear in mind is that the pneumonia associated with COVID-19 is different from bronchopneumonia. So with bronchopneumonia, we have an area of lung that is infected, and then we have other areas of the lung that are not infected side by side. So you still have a large surface area in the lung of alveoli, which are functioning normally. What's different with the COVID-19 pneumonia is that there is a diffuse involvement of the alveoli, so that really you've very little normal alveoli left to provide that transfer of oxygen function. So what happens to coagulation when people are infected with this virus? I suppose the first thing is that we've often seen changes in coagulation parameters in a variety of different sepsis-related coagulopathies. What's particular about COVID-19, though, is that we have almost universal a mild prolongation of your prothrombin time, not by enormous amounts, by maybe 2, 3, or 4 or 5 seconds, something of that order. And most particularly elevated D-dimers in many, many patients. And some patients will show very marked increase in D-dimers in the thousands, even above 4,000 FEU units. What's less common in COVID-19 coagulopathy is DIC, in the sense of consumption of the coagulation factors, prolongation of PTA, PTT, and reduction in platelets. And in the final stages of any DIC, you'll see low fibrinogen levels and bleeding, and that's really not a feature of this condition. What's definitely true is that the prolonged PT and the D-dimers are associated with a worse outcome for people who have pneumonia. So this was the very first paper that described this phenomenon, and as the time goes on up to 14 days, you can see that the non-survivors, the PT and the D-dimers are higher than in survivors down here, and that was significant. And we'll see that fibrinogen really only drops at the very end of people's illness in non-survivors. We found here in St. James's that there was no evidence of a DIC, as I say, no consumption of fibrinogen or platelets in our patients here. But we also found that same phenomenon, which is that the higher the dimers, the more likely that you'd end up with a poor outcome. But the question is whether these elevated D-dimers are a cause of this poor survival or simply a marker of the fact that these are very ill individuals. And this study was just looking at people who were critically ill with pneumonia and comparing COVID-19 cases to non-COVID-19 cases. And there was no significant difference in the D-dimer levels in these two groups. So I suppose what we can say is that D-dimers are elevated in many patients who are critically ill with pneumonia. And it's not yet clear whether this is unique to COVID-19. It's just, I think, that we've been particularly aware of it with this condition. So what implications does this have for people who have COVID-19 pneumonia? We'll all be aware of Virchow's triad, which is the three things that can, in combination, predispose people to coagulation or thrombosis. So injury to the endothelium, whether because of sepsis and activation of endothelial cells, the presence of intravascular catheters, or surgical or trauma. We've also got circulatory stasis, so where people are non-mobile or for some reason the flow in blood vessels is reduced. And then the third arm of this triad is changes in the coagulation factors themselves. In fact, Virchow's birthday is celebrated every year on the 13th of October, just this last Tuesday gone, as World Thrombosis Day. So we remember him and we think about these three different elements when October 13 comes around. You can imagine the patient who is in critical care has absolutely all of these three elements present. So you have changes in the coagulation state from sepsis, you have immobility, and you have plenty of endothelial injury, both iatrogenic from what we do to support patients through their illness and also what the illness itself does. So I suppose one thing to bear in mind is that hospital-acquired thrombosis is a real issue for us, and even in medical inpatients where we give thromboprophylaxis, the rate of ET can be up to 3%. So showing, I think, that we can always expect that there might be some breakthrough thrombosis. For critical care patients in general, rates published have varied between almost 10% and 60%, with higher rates seen in trauma patients. And of course, any of these studies have to be looked at with a kind of a critical eye, because it really depends on whether thromboprophylaxis was given, how much thromboprophylaxis was given. In other words, was it appropriate for their weight and for their renal function, and whether people were detecting symptomatic DVTs and PEs, or whether they were undertaking screening of asymptomatic patients in order to detect them. So you'll get higher rates if you do screening of asymptomatic people. So we're aware that thromboprophylaxis, so giving low molecular weight heparin usually, will decrease that rate by about half, but it doesn't eliminate VTE. So with the onset of, I suppose, our experience of COVID-19 patients, I suppose early on there were some alarming reports about rates of venous thrombosis initially. So it was reported that there were people having deep vein thromboses, pulmonary thromboses or emboli, sometimes unclear whether they'd really embolized from another area. And later on, we began to hear stories of arterial thromboembolism and stroke, and also myocardial infarction in some people. So this was somewhat alarming. And the other thing that was alarming was that these were occurring even sometimes for people who were already on thromboprophylaxis. There's been a recent review of all of the reported incidences of thrombosis, and they're ranging at the lowest level from 3% in one paper right up to 85% in another. So you can see a real variation in the rates of thrombosis. Although what we can say is that it's obvious that critical care patients are more at risk than those patients who are on the ward. And on balance, I think people probably now feel that the rate of thrombosis in ward-admitted patients with COVID-19 is probably something of the order of 3 to 10%. Arterial thromboses are occurring at a rate of about 3 to 5%, and in critical care, thromboses are probably in the order of 20 to 30%, I think would be sort of a ballpark figure. The caveats with all of these studies are that many of them have reported in an interim way, especially in the beginning. They tend to be observational, single centres, small patient numbers. Up to now, really more critical care patients and ward patients, and then lots of differences between the studies around things like the dose of thromboprophylaxis, the screening for VTE, and whether it's taken into account that these patients may die from other reasons. And publication before peer review is, I think, an issue for all of the COVID-19 literature. I'll just mention a couple of the unusual thromboses. So there was a report in the New England Journal of strokes in patients with an association with anticardiolipin antibodies. This is a very preliminary report. It's one-off. It's an IgA antibody. And I don't think that anyone truly believes, to be honest, that there's any clear evidence of a link between thrombosis and antiphospholipid antibodies in this condition. And then again, some other reports of large vessel stroke in young patients, but in at least some of the patients, some significant predisposing risk factors there for stroke. So again, it's hard to sometimes dissect out what is caused by COVID-19 specifically and what is caused by other conditions. But what we can say is that the worse your coagulopathy, the more likely it is that you will have a venous thrombosis at least. So where you have this, what's called the sepsis-induced coagulopathy score, which is a score to try and kind of predict the people most at risk, or where your D-dimers are especially elevated, 4 times the upper limit of normal, or particularly if they're 6 times the upper limit of normal, that seems to be a predictor. But you can see here that we have other risk factors such as age, obesity, and in particular the obesity and the inflammatory state associated with that condition do seem to be particularly synergistic for adverse effects of COVID-19, cardiovascular disease and being iller. But let's face it, these are risk factors that are related to thrombosis in any critical care admission. So whether they're specific to COVID-19, it's hard to say at the present. I think we also need to remember that there's a timeline for VTE risk, which relates to people who are at home, infectious but asymptomatic. We don't know what their VTE risk is. If they're symptomatic at home, how risky is that for VTE? Certainly in the ward I've mentioned, about 5%. If you go to critical care, that's only about 20% of the hospitalized patients. It might be 30%. And then there's some discussion about even discharged patients with reduced mobility maybe continuing to have risk, and that extended thromboprophylaxis could be in order for those patients. And so just to make 2 points, which is that the risk profile for VTE will vary over the illness time course, and that there may need to be some thoughts about VTE prevention in the community, particularly for people who are being managed at home, who never get to hospital, but who are having hospital-like care, for example, in a nursing home setting. And finally, for those people who are having reduced mobility at home. I suppose one other kind of concept around the thrombosis in this condition is that microthrombi have been identified in a number of different studies. And it brings up kind of the concept of pulmonary embolism, which is a piece of clot, if you like, breaking off from perhaps a DVT and traveling through the large blood vessels in the abdomen, in through the right side of the heart and lodging here, causing local infarction of lung tissue. And the concept of pulmonary thrombosis, which is a more widespread microthrombosis within the pulmonary vessels. And this is a CT perfusion scan of a patient without pneumonia, which is the normal situation with all of the lung perfused, and a COVID-19 pneumonia patient, showing really that there seems to be a more widespread interruption, if you like, of the flow of blood through those small blood vessels, unlike the wedge-shaped situation we normally would see in pulmonary embolism. And people have called this pulmonary intravascular coagulopathy. In other words, that that closeness of the alveolus to the blood vessels is causing obstruction of those small blood vessels with thrombi. That's a theory, but it's certainly one that people are actively looking at. So how do we prevent and treat this? Well, we know already that anticoagulants such as heparin are also anti-inflammatory, can give endothelial protection, and certainly may reduce some of the adverse effects of the more ill patients in relation to ARDS, coronary effects, and so forth. And we also know that prior treatment with therapeutic anticoagulation protects you against thrombosis. So if you're already on therapeutic anticoagulation as you come into hospital, you have a reduced hazard ratio of 0.3 for a thrombosis while you're in hospital. Does being on an anticoagulant affect your outcome? Well, we have a few studies to give us a few indicators here. So in this early study, we can see that if you have an elevated sepsis-induced coagulopathy score or particularly elevated dimers, these were significant increase in survival in people who got heparin in this study. Now, the caveat here is that they used heparin in very few patients. There's a small randomized study of therapeutic versus prophylactic anticoagulation showing an improvement in oxygenation and a reduction in D-dimers in therapeutic anticoagulation versus people who were on prophylactic. And here's another study showing an improvement in survival for those who got therapeutic anticoagulation. There is one caveat for anticoagulation though, and that is that the side effect of anticoagulants is bleeding, which I'm sure everybody in this audience is aware. So the overall bleeding rate in this study of 400 patients, of whom 144 were critically ill, showed 4.8% bleeding events, but increased in critically ill patients, and major bleeding was 5.6% in the critically ill. So there's a trade-off. So if you treat with anticoagulation at therapeutic levels, you will see bleeding. And an abstract form, the Stop COVID study, which is a US study of over 3,000 ICU admitted COVID-19 patients in the US, that showed a confirmed VTE rate of 6.4%, but major bleeding in 9%, 2/3 of whom were on therapeutic anticoagulation. So there is a trade-off, there is a downside, and so that's why I think up to now people have been reticent to go straight to therapeutic anticoagulation for these critically ill patients. But there are lots of critical care trials, as well as trials in ward patients, trying to sort out whether we need therapeutic or intermediate dose or prophylactic dose in the various cohorts of patients. A lot of open questions for VTE in COVID-19. So, you know, should we be using fixed dose or weight-based dosing? Certainly the HSE guidance is to use a graduated weight-based dosing so that we're sure that the heavier people are getting the correct dose. And I don't think it's known yet whether higher dose prophylaxis or therapeutic is required if you don't have a VTE. We don't yet know what level of D-dimers might be useful to tell us which patients should have therapeutic anticoagulation, and what would prompt evaluation for a VTE. Certainly symptoms would, but you know, in the critically care patients, sometimes it's their clinical parameters which are deteriorating, which prompt that move to therapeutic anticoagulation. And again, there's been some anecdotal evidence that, you know, people are treating individual patients with therapeutic anticoagulation because their dimers are particularly high. Certainly, screening is not the norm here in Ireland, so we tend not to go looking for asymptomatic DVTs, but obviously critical care patients can't always tell us when they have a DVT, so that's one question that's still open. And the bleed rate trade-off, we're beginning to get a little bit of information on that now. And how long should it continue? Nobody knows. This is the international guidance. So this is a consensus document endorsed by a number of our leading societies and groups, really suggesting that hospitalized patients, assuming there's no reason to not give them prophylaxis, for example, bleeding at the time, should receive a low molecular weight heparin thromboprophylaxis, but not giving us too much guidance as to dose and agent. The HSE, as I've mentioned, suggests that we should risk assess all of our patients for VTE on admission, but also bleeding risks are important because, as I've mentioned, it is a trade-off. We give thromboprophylaxis according to weight and renal function, and patients should get information, especially on discharge, about VTE signs. So the take-home messages for COVID-19 pneumonia and coagulation is that elevated D-dimers in this condition are associated with adverse outcomes, but we don't know yet whether that's just unique to COVID-19 or actually just reflecting the severity of the illness, nor do we have a good predictive value for D-dimers, unfortunately, so the positive predictive value of dimers is low. Thrombosis is a feature though, and it can be pulmonary thrombosis of small blood vessels in the lung, it can be pulmonary embolism and DVT, and it can be arterial thromboembolism. To risk assess and prevent VTE is very important, and then treatment, picking up the symptomatic patient and treating them. But at the moment, we await really high quality clinical evidence to inform us regarding the risks and benefits of therapeutic anticoagulation and in which subgroups of patients it would be important to use this dose of anticoagulation. So just mention Thrombosis Ireland just for any in the audience who have any personal or family experience of thrombosis. This is a fantastic patient organisation started by a patient of ours, which supports people who've had thrombosis, and just giving a flag there for World Thrombosis Day, which we've just had on the 13th of October. So thank you very much for your attention, and thanks again to Jared for the invite to speak.